Hi, everyone. Good evening, and welcome to the NATF online support group. Thank you for joining us. Tonight, we are delighted to be joined by Dr. Elaine Heilich, who is a professor of medicine at the Boston University School of Medicine and a practicing physician there. She is a longtime friend of NATF and world-renowned expert in anticoagulation, and we're really excited to have her with us tonight to discuss a topic that's really important to patients on an anticoagulant, which is how to safely stop that anticoagulant if something like a simple tooth extraction or a more invasive procedure. So with that, I'm going to turn it over to Dr. Heilich. Just one quick housekeeping note: if you want to submit a question, please use the chat function, which is on the toolbox that should be appearing on the GoToWebinar control panel. Or you can send an email to info@natfonline.org, and we will get to those at the end. So with that, Dr. Heilich.
Great, thank you so much, and welcome everyone, and really thank you for dialing in for this evening program. Let's go right to the next slide. These are my disclosures. I think it's very important that anytime someone is standing at a podium or on a stage or being asked to give a webinar, that, it's important for speakers to disclose what type of work they've been doing with industry. And as you can see, I've been on multiple scientific advisory boards, as well as actually have participated in some of the really pivotal trials in this area. So with that being said, let's go to our next slide. And one real shout out that I'd like to give tonight is for the World Thrombosis Day, which is a global, believe it or not, a global initiative, a program by the International Society of Thrombosis and Hemostasis. And I will show just a few slides, perhaps 4 or so, to really highlight the amazing work that's being done to highlight really the awareness of DVT, deep vein thrombosis, as well as pulmonary embolus, and in addition to that, also atrial fibrillation. In March, this month, is Blood Clot Awareness Month. And if I turn your attention to this next slide, Introduction to World Thrombosis Day, as I stated, this is a really global movement. It happens the same day every year, October 13th, which is just incredible. October 13th has special meaning to all of us in the thrombosis community. Because it is the birthday of Rudolf Virchow, who was the very first individual to really help us understand what are the factors that drive clot formation. So every October 13th on his birthday, to really honor his brain and his insight, we really celebrate. So in 2018, this past year was our 5th year anniversary, and we had 1,500 partners and 16 financial supporters really worldwide who hosted multiple events to try to increase the awareness. So if we look at just briefly the mission, it's to increase global awareness of thrombosis, including its causes, risk factors, signs, symptoms, and evidence-based prevention and treatment, and ultimately really to strive to reduce death and disability caused by this condition. The mission is supported the World Health Assembly's global target of reducing premature deaths by non-communicable disease by 25% in 2025, as well as the World Health Organization's global action plan for the prevention and control of non-communicable diseases. And you can see thrombosis is really a major issue, with 1 in 4 people worldwide will really die of a condition caused by a thrombosis, and a leading cause of global death and disability. So the objectives for World Thrombosis Day, before I dive into the crux of our discussion tonight, is again to highlight the burden of disease, increase public awareness, really to empower individuals, because I think, you go to a doctor's office and you have some questions for him or her, but somehow you just never, kind of get that question out. And I really think it's important, to share your concerns with your physician, nurse practitioner, physician assistant, I mean, whomever, your surgeon, because ultimately you want to be, aware of what's going on. And that's part of the reason for tonight's webinar. And then finally, the fifth, and I think this is a very important one, is to advocate for systems of care. And so we've really done a lot of work and continue to do a lot of work, looking at the inpatient, the hospital setting, trying to improve the care, quality of care, educating our house officers, residents, fellows, and just making sure that we're all really doing the best thing that we can for our patients. And this is just some examples. I would urge you, if you have a pen right now, to write down worldthrombosisday.org. That is one word with no spaces. It's a website, and it is just full of immaterial, a lot of material, a lot of things that you can really educate yourself and your family members about thrombosis, how to prevent it. A lot of different evidence-based PDF files and things are on there. So I really encourage you to look there for yet another resource to learn about thrombosis and anticoagulants. So the first portion of this, let's say maybe for the next 10 minutes or so, I'm really going to focus on venous thromboembolism. But I do have a few slides embedded at the tail end of this presentation that at least will touch on atrial fibrillation, just in case we have any participants this evening that might have a question relating to atrial fibrillation. But let's just start with venous thromboembolism. What do I mean by that? Well, those are the clots in the legs. Those are referred to as deep venous thrombosis. And if it happens to embolize from the leg to the lung, that is then a PE, or a pulmonary embolus. And we think that the average annual incidence is about 108 per 100,000 person years. And about 900,000 incident means new diagnosis. That's a new diagnosis. That's opposed to prevalent. So 900,000 new diagnoses or recurring events per year in the United States, and about 762,000 or so in Europe. There's an estimated 296,000 PE deaths. And as I've already alluded to, it's the third leading cause of cardiovascular death after myocardial infarction and stroke. We know for a lot of reasons, complicated biology, as well as just sort of what starts to happen to us as we get older. But we know that the incident rates of venous thromboembolism really increase substantially with age. And we also know, and I'm going to really get into this in greater depth as we go through this slide deck, but about 30% of patients will develop a recurrence within 5 years. This is a DVT or potentially a PE. But I will go through those factors and show you the evidence for that. The post-thrombotic syndrome, this refers to venous stasis in that swollen leg that a patient might have after you've had a DVT. You can also develop some skin breakdown and develop venous ulcers. We think that post-thrombotic syndrome occurs in upwards of 30% of patients with a proximal DVT. And about 4% of patients, actually might be just a little bit less, of patients with a pulmonary embolus can actually develop kind of hypertension within the pulmonary tree. So as I had stated, I mean, this is a nice, I think, again, this is a good reference in this slide deck, so hopefully this will be available for everyone. But this is a population-based study in Western Australia. And you can really see from this diagram, this figure, that the annual incidence of symptomatic DVT or PE really just is exponentially increased as we get older, especially, let's say, over age like 60, 69, 70, 79, over 80. Now certainly some of that has to do with the fact that we're having, orthopedic surgery. We may be in and out of the hospital. But in addition to sort of the setting and the different things that start happening to us, there's also just this biology that as we get older, we tend to not always like our bodies aren't as how do I want to say, vigilant for thrombosis formation, and I think that is something that may be contributing, or maybe one of the factors that contributes to this phenomenon that we see with age. So what are the risk factors for venous thromboembolism? And I'm going to have you look really first here on the left side, because these are very important things to think about. We have the setting that can really be a major trigger for a venous thromboembolism. And then we have, well, what's happening with the patient, him or herself? So if we focus first on the left side, we know that surgery, I would say almost any kind of surgery, but certainly orthopedic surgery, a knee replacement, hip fracture, where you're really immobile and you're not moving, that venous circulation is somewhat static. Surgery is a big risk factor for deep vein thrombosis, which is why, I mean, hospitals are aggressive and trying to figure out, what surgeries, what patient characteristics, all these things do we need to be sure to institute DVT prophylaxis, meaning that you would be given an anticoagulant while you would be in the hospital. You might remember having an injection, which would be one way to go. And then we certainly also have some oral medications that we can also use. Certainly trauma is another one. Again, trauma largely, again, because you might have crush injuries, which can release something called tissue factor. Your body, you may have subcutaneous bleeding, soft tissue bleeding, which is telling your body to clot, hurry up, make a thrombosis. I mean, your body really is kind of getting confused, so that, you're developing a hemostatic plug, but sometimes, we just go too far and end up getting a DVT in the leg, and hopefully that won't embolize to the heart, or to the lung, I should say. And then we have heart failure, which I will share with you as a physician that the term failure is really a misnomer. I wish there was some way we could eradicate the word. Our hearts really aren't failing. When you hear this word congestive heart failure, basically the heart is a muscle, and it, sometimes might be just a little weaker than it was when you were 27 years old. It certainly doesn't mean it's failing. So anyway, just so patients don't get frightened by some of these terms. Acute respiratory failure, again, this term failure, but that really, I think, largely is looking at patients with, emphysema, that are having some trouble breathing. And sometimes when we're having difficulty breathing, that can be transmitted into our liver isn't working well. I mean, there's just a lot of things that start to come into play. But, individuals who might be admitted for what we call a COPD flare, or pneumonia, for example, or, a bad asthma attack, we do know that slightly increases the risk. I mean, realize that even though I'm talking about these factors, the absolute risk, what are the numbers? Well, the numbers are clearly not great, not high. I mean, it's just that we know that where the hazards lie are in certain conditions, and that's why we try to be more attentive and vigilant to these different things. So now if we move into that middle box, that kind of diamond area, we know that cancer, malignancy, certain types of cancer really are very prothrombotic. And we know that different types of inflammatory disease, things like lupus, even HIV or hepatitis C, inflammation in the liver, inflammation in the joints, can kind of set us up as well for a more prothrombotic state. And then if we look over here at the right side, the patient characteristics, probably one of the most important risk factors is if you've had a DVT or a PE in the past, that's actually a pretty important risk factor for having another one. So that's important. We already talked about some heart dysfunction. We talked about advanced age. I think varicose veins, I would leave that on the list, but certainly that's not a huge risk factor. I mean, more for superficial thrombophlebitis opposed to that deep vein, femoral vein type of clots that you would see and really cause the problem. Obesity, we all have to own that one. Obesity is definitely a risk factor for developing a DVT. So, I mean, you got to work to get your body mass index, down. Exercise, nutrition, portion control, all that type of stuff. And then we've already talked about immobility, paresis. You've had a stroke and that leg or arm is not working. Pregnancy is a big risk factor, surprisingly. As well as some of the hormone therapies, as well as renal insufficiency. So I do think it's important, especially for younger women, that some of our oral contraceptives, birth control pills, actually can be prothrombotic. So I usually ask my patients if they have any family history of DVT, PE, things like that before I'll be eager to just flippantly give oral contraceptive without really knowing which one it is. So we're talking about stopping anticoagulation tonight, and are we really stuck with these therapies for the rest of our lives? So we're going to really talk about venous thromboembolism first. And if we look at the risk of VTE recurrence after stopping an anticoagulant, really depends on the risk factors that were associated with the initial thrombosis, the first time that you had the clot. So if it was a transient or a reversible risk factor like surgery or trauma, things like that, or you're smoking cigarettes and you're on a birth control pill, but now you've stopped smoking cigarettes and you're no longer on the birth control pill. Like these are transient and reversible risk factors. So that the risk of that clot coming back is really low. It's about 3%, so 3 of 100. If you have a continuing risk factor, and here I guess the most prothrombotic risk factor would be cancer, that's over 10%. And then we use this term idiopathic or unprovoked, meaning if I've ruled out trauma, I've ruled out surgery, I've ruled out a recent hospitalization, I've ruled out the birth control pill, ruled out all these other things. If you can't come up with a reason for this clot, then we call this an unprovoked clot because we just don't fully understand, what's happening inside the bloodstream in this particular soul. And so what we do there is we tend to continue anticoagulants with patients who've had this unprovoked clot. And I can show you, I think this really illustrates it nicely, this figure. So this is a study coming out of the United Kingdom that stretched from the year 2001 to 2011. And what this graph is showing you is the 10-year recurrence of venous thromboembolism. And you can clearly see that if you had an unprovoked VTE, that red dashed line, that when you hit the 5-year mark, I mean, most of us say about 30% at the 5-year mark. In this particular study, it's probably closer to 25. But I think most of the studies come down at about a 10% 1-year recurrence rate, which is clearly shown here. But in other words, like, can you ever stop an anticoagulant? And I think that's really a individual patient decision to say, what's the risk of bleeding if I stay on this medicine? What's the risk of me having another DVT if I come off of this medicine? And, even though we try very hard to come up with precise rules about who's more likely to have a recurrence, our science is not yet there to really be able to pinpoint this with incredible accuracy. But certainly the one thing we do know is that provoked clot really does not carry the same risk of recurrence, and I think that's very important. So there's many studies. I mean, John Haidt published this. He's a very prolific investigator in this field. And let's take a look at the independent predictors of recurrence. So for some reason, men seem to be at higher risk of having a recurrent DVT if they've already had one. So for some reason, again, we don't quite understand why this is the case. We all have our theories. But that is just important. So women slightly, again, decrease risk, and that may play into a decision to come off the medication that, when you really sit down and think about this with your physician. Increasing age, we've talked about. We've talked about obesity. We talked about neurological disease, and you might have a paralysis or a weakened limb. Active cancer is a very thrombogenic state. We talked about lupus, a lupus anticoagulant or antiphospholipid antibody syndrome, which are special syndromes within the thrombotic category, as well as some of the other inherited, actually thrombophilic factors, so antithrombin, protein C or protein S deficiencies, another one which is called factor V Leiden, and if you have certainly combinations of these, that may also slightly increase your risk. And we're still a little bit confused about the role of what's called a D-dimer. A D-dimer is kind of a breakdown product of a clot. And if you measure this protein in individuals' plasma, you'd be surprised that it's really a wide range of this D-dimer, even among individuals that don't seem to have an active clot. So we're trying to better understand how this D-dimer might fit in and whether or not it might be helpful. There's some sort of preliminary, I wouldn't hang my hat on it, I suppose, but there's some preliminary suggestion that a very low or negative D-dimer in women tested about a month after you stopped the anticoagulant may help you decide to come off the anticoagulant. But again, this has not reached the guideline level yet, but there are some studies that suggest that it might be helpful in women, could never be helpful in men because the risk is just still too high in men. So if we look at the duration of anticoagulation treatment, so again, just to review, if you've had a provoked or a transient risk factor that has what we would consider a low risk of recurrence, so here you're really going to stop treatment at the 3-month mark. I mean, after you've been on 3 months and you're sure it was transient, and listed on this slide are the ones that we would consider reversible, I should say: surgery, trauma, immobilization, lengthy travel, estrogen therapy like birth control pills, or pregnancy. But if your clot was more on this, we can't really find a factor. As we said, this has a high risk of recurrence. And for these patients, I do think that most people are erring on the side of not allowing a clot to recur, and they're continuing anticoagulant treatment on these patients. I would encourage everyone who's interested. I mean, if you go online, I'm pretty certain the CHEST guideline and expert panel report, the antithrombotic therapy for venous thromboembolic disease. It's nice to download these documents because at least you can get a sense as to what's right now somewhat considered like the guideline, the standard of care for some of these things. So that would be the reference for that. The CHEST journal in 2016, I believe, was the most recent update. So whenever I was asked to give this topic, I mean, we can talk about stopping these drugs permanently. I want to be off this. I had my DVT, was treated for 3 months. But what about individuals who might have to stop, or do they have to stop if you have a procedure that's coming up? And what are your risks if you stop these medicines before a procedure? So these are the 3 questions that I would be asking. The first is, I would ask, do I really need to stop my medicine? Yeah, it's a blood thinner, but what kind of procedure am I having? If the surgeon or the oral surgeon, the dentist or whomever says, absolutely, I really want you to be off this blood thinner, then you would want to say, well, then for how long? Because sometimes what we see is like the doctors don't talk to one another. The communication breaks down. So, you go into the oral surgeon and you have, 5 teeth removed or whatever, and then someone is assuming someone else is restarting this medicine. So, these transitions in care, multiple different settings are very, very important to know, like, when is it going to be safe for me to restart this medicine? And then that's the third point. When is it safe to restart? Because these are blood thinners. This doesn't mean that your blood isn't going to clot. Of course, it clots. It just clots a number of seconds. Believe it or not, it's not like minutes or hours. It really comes down to a number of seconds. Your blood just takes a little longer to clot, so you wouldn't want to have any type of bleeding complication, which is why it's important. So, do I need to have it stopped at all? If I have to, then how long do I have to be off it? And how quickly can I get back on my medicine? So I think this is a great slide here. I put this together. This is based on a lot of different studies. If you look at the bleeding risk of the procedure, no discontinuation. So for a lot of dental procedures, extraction, at least in this study, of up to 1 to even 3 teeth, you can probably get away with doing these minor procedures, I should say, without stopping your blood thinner, your anticoagulant, I should say. Cataract surgery, if you're having some type of endoscopy, if you're having a dermatology, like minor type of excision, you really don't have to worry about bleeding. Low bleeding risk procedures. Here you can see endoscopy with biopsy, a prostate or bladder biopsy. Even now in the cardiology field, the catheter ablations for atrial fibrillation, pacemakers, these are all now being done while the patient is on an anticoagulant. The higher bleeding risk procedures, this is really where you would not want to have any type of bleeding, because the space is a critical space where you would not want to have any type of a hemorrhage. I mean, clearly around your spine, any type of epidural anesthesia, you do not want to risk ever any kind of bleeding in that space, because it could obviously affect your spinal cord. Any type of thoracic, abdominal surgery, major orthopedic surgery. These are high bleeding risk procedures. And then if you're doing a biopsy of an organ or a viscus that's deep inside the body, like the liver, the kidney, again, you're not going to take a chance on any kind of blood thinner being involved. And so for those procedures, you're definitely not going to be on your blood thinner. For the interest of time, I mean, this is just from the Bridge trial, which I think looked at an atrial fibrillation population. It was a randomized trial looking at whether or not we need to bridge warfarin. But this really, I only put this in here because it again sort of reaffirms what a whole other group of individuals, thinks are considered minor or low bleeding risk surgeries or procedures. So that was really the purpose of this. And which procedures are the major or high bleeding risk surgeries? And it's really what I said. So intra-abdominal, thoracic, major orthopedic, urologic procedures, or some other type of major procedure where you really just can't chance any type of hemorrhage. So I also wanted to put up some pharmacokinetics for everyone tonight, because this is actually really important. We've been so used to using warfarin for almost 60 years now, but we have many newer drugs. I'm sure many of you are on some of these: apixaban, rivaroxaban, dabigatran, edoxaban are the main four. These are very, very different from warfarin. And what I've highlighted here, first of all, is what I call the hours to C max, okay? What this means is how many hours after I take this pill will I have the maximum effect of the drug. and it's remarkable and it's very different. So if you had been on warfarin or if you're still on warfarin, it really takes about 3 to 4 days before the anticoagulant effect of warfarin really kicks in. And this is in striking contrast to those novel or newer oral anticoagulants that I had just stated, and you can see on this slide. All of them really have a full anticoagulant effect within about 2 hours. And this is critically important because if you just had, 7 polyps removed from your colon, you really want to be talking to that endoscopist about, when can I restart my medicine? Because, within 2 hours after taking that pill, you are fully anticoagulated. So again, this is where you have to communicate with your physician on when they think it's safe to get you out of the risk of bleeding, which is obviously the other part of this. The other issue is the half-life. So what does that term mean? So half-life means, how many hours does it take before 50% of this drug is gone? So this is, that's what the half-life is, so pharmacokinetic-wise. So you can look at warfarin, 40 hours. Think about that. That's a day and a half. So within a day and a half after holding warfarin, you still have 50% of warfarin and its effect in your blood. So that's why these are very different medicines. Where if you look at these other agents, dabigatran, rivaroxaban, apixaban, edoxaban, the half-life here is much shorter, meaning that when you stop that medicine, within about 10 hours, 50% of it is already gone. Okay? And then the other thing I think that's important for our patients to understand is just how much of these drugs is the kidney responsible for eliminating, and it's different. So with warfarin, which is our standby for mechanical valves now, and actually a lot of patients will remain on warfarin, you can see that it's really not at all eliminated by the kidney. So kidney function is really not necessary for warfarin's metabolism. But it is important for the metabolism of these other newer DOAC agents, we call them now. So that dabigatran has about 80% of the drug is cleared by the kidneys. And then you can see with rivaroxaban about 33%, 25% for apixaban, and about 50% for edoxaban. So the ERA practical guide, the US guides are very similar to this. That stands for the European Heart Rhythm Association. I think this makes sense, that anytime we're going to temporarily stop one of these medicines, it really is going to depend upon, one, the risk of bleeding associated with the procedure itself, and then it's going to depend upon what is the patient's kidney function. So you can see with dabigatran, remember that was 80% cleared by the kidney. So that as you move down that creatinine clearance, that means that the renal function is getting less and less good, 30 to 50 or less than 30. You can see the number of hours that you're going to be holding that particular medication if it's a low-risk bleeding procedure versus if it's a high-risk bleeding procedure. And then what we call the factor 10A inhibitors, apixaban, rivaroxaban, and edoxaban, here because they're less dependent on the kidney, you can see that the time to hold them is actually considerably shorter for the low risk as well as for the high risk group. But again, these would be decisions that, our patients would not be certainly making on their own. I mean, this is going to be a conversation with whoever is doing the procedure, as well as probably your internist or your cardiologist. So we've already talked about that hours to C max, so that because the minute you take these medicines, very important to know when it's safe from the bleeding standpoint to restart the medicine. But we also know, again, with these newer drugs, the dabigatran, rivaroxaban, apixaban, because when you take it, you're almost immediately anticoagulated. there is really no role for the old injectable, low molecular weight heparin to sort of bridge until that drug is effective, which was necessary for some patients anyway, with warfarin. So I think over just the next few minutes, I wanted to just very quickly talk about atrial fibrillation because I thought we may have some listeners today with AFib. The guidelines were just updated with atrial fibrillation by the American Heart and American College of Cardiology Heart Rhythm Society. And, these guidelines, I mean, you just go online and you should really be able to download these. And again, literally just hot off the press in February 2019. So for patients with AFib, I kind of think a little bit unlike the patient with a DVT or a PE. I think most physicians now are really continuing these medications, and it sounds incredible to say, but I'm going to say it for life. Because the risk of stroke can be quite high if you have atrial fibrillation. And again, it depends upon what your risk factors are. And we use something called the CHADS-VASc score, which you can see written there, and that stands for congestive heart failure, hypertension, age over 75, diabetes, prior stroke, vascular disease, which means do you have coronary disease or have you had a heart attack in the past? And then the SC stands for sex category, which because we still think women are at higher risk of having a stroke in atrial fibrillation, but we really don't see that until women get over age about 65. So this is just showing you that in the guidelines now, the options still include warfarin, although I do think that the DOAC medications have now given a preference just because of their ease of use, and you don't need to monitor these drugs. But again, I mean, if you and your physician feel that warfarin is the better choice for you and the INR has been in range, which I think is important, just important to realize that, you want to be sure that you're getting checked at least monthly, your INR. At least that's what the American Heart recommends. Another issue I wanted to highlight is that once you have experienced atrial fibrillation, again, it goes back to that CHADS-VASc score. If your CHADS-VASc score is 3 if you're a woman, or if it's 2 if you're a man, then it doesn't matter if that AFib is paroxysmal or if it's there all the time, like permanent, because we can't predict when atrial fibrillation may pop back in. And because of that, I think most doctors err on the side of protecting people from having a stroke. This is an evolving area, I will say. Very active, a lot of research going on right now with the paroxysmal piece especially. So that may be changing in the future. But for right now, we really pretty much ignore the pattern of atrial fibrillation. And then I think this is just about the last slide, just again talking about the bridging. So that the warfarin, if you have atrial fibrillation, if you have a mechanical heart valve or mitral stenosis, you will remain on warfarin. These newer drugs do not work with mechanical heart valves. But again, because of this remarkable difference in time to full anticoagulation, we now know that we don't really need to be using low molecular weight heparin with these newer agents. So I think here we have about 18 minutes or so for questions, 20 minutes. So do we have any questions from our attendees tonight?
All right. Well, thank you so much, Dr. Heilig, for such a thorough and really informative overview of this topic. We have a bunch of questions, actually, probably more than we have ever received, which is great. So, kind of the ones that have come in over the chat box, a bunch of them really want to know more about what exactly is the risk of sitting for long periods of time, as well as a sedentary lifestyle. If you could talk a little bit more about that as an actual risk
Well,
factor.
I can remember whenever people were like doing these like megathons and watching, television for like 72 hours in a row, like with some of these Soprano and all these shows that people were doing this like binge watching and whatnot. Um, I think the risk is there. I think the risk is small. I'll be honest with you. Because even with the long plane rides, I mean, you could be on a plane ride flying all the way to South Africa, which is going to be about a 16-hour plane ride. And, everybody isn't coming off that airplane with the DVT. So I'm going to say for that particular question that, how long would you have to sit? I mean, I think it's just important to get up. I mean, get the steps in, 10,000 steps a day. So as far as the actual risk of, sitting around a lot for that first question, like how many hours, for example, when we apply the VTE risk factors in the hospital and we use the term immobility, this is just to give you some perspective. Immobility, when we apply these predictive rules, is 3 days or more lying in bed, getting up and using the John. 3 days. So that's why, I mean, I tell people, I just, I don't think it's healthy to be sitting around binge watching for 3 days in a row. I mean, you got to get up, you got to move. But it's really, it wouldn't certainly reach the 3 days of lying in the hospital. Just to give some perspective, the risk is there. I think the risk is very low because in the hospital, we don't see the risk increase until you've been flat on your back for over 3 days. Regarding the sedentary lifestyle, absolutely. Like this is a problem. And, we need to start getting ourselves in shape. I think there is so much research now. I could go on and on. We should just have another webinar on this alone. If you look at cognitive function, very interesting. People have less risk of developing dementia, cognitive impairment with exercise. It's like, who would believe it? If you look at the Framingham Heart Study, which is actually, as people know, centered at Boston University, and you look at the size of people's brains, like you wouldn't think this is possible. So that the Framingham Heart Study has followed people, I think, since 1950, and they have done, as part of the study, the NIH-sponsored study, they've serially actually looked at MRIs of patients' brains, and they've literally been able to correlate the level of physical activity with the volume of your brain, which sounds hard to fathom, but it's really quite true. So that if you are used to doing some form of exercise, again, we're not talking about people getting out there and doing 10Ks or starting to jog. I mean, I tell my patients to look, get out there, try to do, maybe 30 minutes, 40 minutes a day, find a nice path in your neighborhood, maybe build in, a small hill here and there, do a little bit of interval training. But that is so, so important. It's not only important for your heart, it's important for your cognition, and it also stimulates your immune system. So, what can we do to try to not get sick as we get older? That's just all really important. And clearly we don't have time to get into nutrition, but that's another one. Anyway, I could go on and on about the sedentary lifestyle, but hopefully that answered that question.
Yes, absolutely. So the takeaway there is get up and move.
That's that would be saying it quite shortened version of that.
Great. And then we had a couple of questions come in. People, with questions about getting a colonoscopy. If you could just talk a little bit about that and when you might consider stopping for that.
Well, that's a tough question to answer because, it's the endoscopist the colonoscopy, the GI doc, the last thing he wants on his watch is a polypectomy that bleeds, okay? And there are characteristics of polyps that bleed. Multiple polyps increases the risk of GI bleeding. You know, the polyps that are flat based, where you have to really, it's not just a simple, you know, snip on a stalk, but the polyp is actually like more mucosal. Those have an increased risk of bleeding. So, you know, it's that's a tough question to answer because, you know, a lot of people say, okay, fine, we could do the colonoscopy while the patient is fully anticoagulated and then take a look and see what's up there. But then what sense does it make to then have the patient have to come back? So I think most of the time, you're probably gonna at least hold a few doses for the colonoscopy, just in case there's a lot of polyps that the endoscopist has to remove. Clearly, like removing one or two, even probably three is no big deal. But remember, when everyone used to take warfarin, we would just restart warfarin the night of the colonoscopy because it takes 3 to 4 days before it reaches the full anticoagulant effect. And I think that these agents that have come out over the last few years, I mean, if you have 6 polyps removed, you are not going to be restarting that anticoagulant the night of the colonoscopy. I mean, you're at least going to wait until the morning to restart it. So for that question, I mean, I think it's going to a little bit be individual based. It's going to be based on, well, how high are your risks of you know, coming off of the medicine, and what are the likely bleeding risk if we keep you on and just try to do it while you maybe just miss the evening dose of the twice-a-day drug. But that, again, that really has to go through your colonoscopy physician because they're the ones in charge there.
Okay. All right, thank you. The next question is from a woman who had a PE after having a C-section. She's also had another blood clot after an injury, and she's been on Xarelto for several years since that recent DVT. Or no, I'm sorry, that was also PE. But I guess she's now, one of her doctors recommended that she come off of an anticoagulant or come off the Xarelto. So she's kind of wondering if you have any kind of input about that given her history.
Well, I mean, so here we have, I mean, how would I answer this? Let's start with this. Not every woman who has a cesarean develops a blood clot and has a PE, okay? So if you just look at that, so there's something different there, just at the get-go. The fact that there was then a subsequent injury, like an isolated event, that injury, I would say, well, that's clearly another provoked clot. Like I can clearly see, you know, why that happened. First, there was the C-section. That was the pregnancy is a high risk time, and then you're having surgery on top of it. That's very high risk time. And then I don't know how many intervening years there were between the C-section and then the second pulmonary embolus from the injury. You know, what was the degree of injury? Like, was this a massive crush injury? Was this, you know, something that you could say, well, you know, maybe that because it was just an overwhelming risk factor for a PE or a DVT that, you know, maybe we could say that these were two really isolated events. But boy, I don't know. You know, I don't want to give advice because I don't really know the details here. If there was blood work or anything else that might put me in the camp of one side or the other. But my knee-jerk reaction is that there's been 2 provoked clots, and I'd be nervous about stopping it. I'd be a little nervous about it. But I can understand if there's been a lot of years that have gone on and there hasn't been any issue. I mean, the one thing that, you know, this person might consider is, given that there has been some evidence about this D-dimer testing, that, you know, maybe when she's comes off of the rivaroxaban medicine, she could have that D-dimer tested, because at least if that was very, very low, you know, that might be a reason. But it sure sounds like there's some underlying predisposition But I don't know how serious the injury was for that second insult. But a D-dimer might be one more, piece of data that her physician would think about and she would think about.
Okay, great. So we had a couple questions come in from patients who are currently on blood thinners and kind of along the same lines of this last question, and they're just nervous to come off of the blood thinners. Their doctors are telling them it's okay, and they're just nervous. Do you have, I guess, any kind of points of or helpful tips on how to speak with your healthcare provider about that?
Well, I'll tell you, I think the first thing that I do for my own family, and I encourage my patients to do, is just become as educated and knowledgeable as you can. Tonight I think we went through the current understanding of what causes these clots to recur, to come back. I think that if you really think about the context and the setting of that first clot that you had, and if you were fully treated for 3 months and it was definitely something that was reversible, then I would come off. For me personally, I would definitely come off. I mean, I would say 3 months is it's fully treated, it's consistent with the guidelines and our understanding of the biology. But I think, I would also, I mean, we gotta, if I'm really overweight, I'm gonna work on getting my weight down. If I'm currently a cigarette smoker, I'm gonna work really hard. It's tough, but that's another risk factor. You're gonna work hard to reduce the things that are setting you up for another one, which would be, the sedentary lifestyle, being overweight, cigarettes. I mean, these are all, important factors. I will tell you the guidelines right now. If you've had one unprovoked clot, that one that we don't know what caused it, the guidelines say it's really kind of sit down with the patient. And this is probably what they're asking. I mean, I think that these newer agents, they had a really, I think some of them anyway, have safety profiles. Remember, you're always going to be at risk of having a bleed with these medicines. You want to be careful to not take things, like ibuprofen, which can increase the risk of upper and gastrointestinal bleeding. You should really not be taking a daily aspirin unless your doctor has specifically requested that you stay on an aspirin, because when we combine the aspirin and the ibuprofen with the anticoagulant, these are the things that we're doing that are increasing the risk of the bleeding complications, really on any of these blood thinner drugs. So that would be, something that would be important so that we can at least minimize the risk of bleeding. But I think when it comes to that clot, the first unprovoked DVT or PE, you're really going to sit down after that 3-month mark, the 4-month mark, and say, all right, my risk of bleeding is this, my risk of having another DVT is X. If you've had two, I don't think there's anybody that wouldn't say you need to be on this medicine for life. Certainly the second episode, I don't think there's any wiggle room there. There might be some wiggle room after the first one. And like I said, although I don't want to say that this, again, has not yet reached the guidelines, but there are paragraphs in those guidelines that really do get into more of this D-dimer testing. And I mean, at least that's something that to me might make sense. So after you've been off the blood thinner just for a month, or you can even, believe it or not, check the D-dimer while you're still on the blood thinner. But I would, that's just one piece of at least biological information that may be informative. But if I still have a big swollen leg, and if my D-dimer was still moderate to high, I mean, I personally would not want to come off the blood thinner. For me, that's me.
Okay. All right. So this is a question that I think is kind of falls in nicely to what we've been talking about in terms of risk factor. But there was a gentleman whose husband had a PE from some trauma that he suffered, but he was also overweight at the time, and he has since lost 50 pounds. And they're kind of wondering now if, given the weight loss and because the blood clot was because of a traumatic or some sort of trauma, if he should consider coming off of the warfarin?
Well, I mean, here, let's see. I mean, let's just, from my understanding, then, this is a male, so he's going to be at higher risk of a recurrence. But forgetting that, I mean, again, the most powerful risk factor was the setting of the first clot, the first event. So if this was truly trauma, like thrown from the motorcycle, in the car accident, fell down 12 stairs, I mean, if it's truly trauma related, or related to a post-operative setting, then that is absolutely a reversible risk factor. So now, if you're working along that premise, and now the individual, amazing, terrific job, has lost 50 pounds and now hopefully got that BMI to be less than 30, then if it were my patient, just giving those limited facts, assuming those are the facts, I would think that it's hard to justify continuing the risks of being on an anticoagulant, which would be bleeding in that instance.
Mm-hmm. Okay, awesome. See, so this is a question from a gentleman who has prothrombin gene mutation. His sister just had a PE, but he has a 20-year-old daughter who is on birth control but has not been tested for any, genetic clotting disorders. Do you have any advice as to what steps he should take?
So, first of all, when we talk about the genetic mutations, okay, the antithrombin, protein C, and protein S,
Mm-hmm.
Believe it or not, the factor V line and the prothrombin gene mutation aren't quite as potent as underlying thrombophilic genetic mutations as you might think. So that in Paul Ritker's study out of the Brigham, I think he actually found that being obese was more of a risk factor for a recurrent DVT than either the prothrombin gene mutation or the factor V Leiden. Now that's heterozygous on the factor V Leiden. Now that you might have combination, you might have the factor V Leiden and the prothrombin gene mutation. But I'll tell you what I think we're probably going to end up finding at the end of the day is that there may be something else going on too that we just don't have the science yet to really understand the interplay. So I absolutely agree that factor V Leiden and the prothrombin gene mutation can increase your risk. But it's, at least in the Paul Ritker study, it was not even as much as the obesity was. So let's get back to this gentleman. So if I have a family history, it's really the family history is more compelling, I'll tell you, than even like running the genetic profile. If my mom had a PE that was unprovoked, or my sister, I don't think I would want, my daughter to be on the birth control pill. Or let me just think this through a little bit. I would definitely be looking for the ranking of the oral contraceptive pills and their likelihood or their risk of venous thrombosis, and they really do differ. So I would really ask this caring father to run the list and to look to say, which of these oral contraceptive pills that are out there now have the highest like prothrombotic risk and which have the lowest risk. And you can easily find that information. So that, I think that would be more what I would probably recommend, would be not to necessarily have her come off, but at a minimum, consider an IUD, which I think that's a very personal decision. Or if not that, then certainly be sure that she's on the lowest risk birth control pill.
Okay. Excellent. All right. Well, we are about out of time. Do you have any kind of final words of wisdom for our group this evening that you'd like to share, Dr. Heilich?
Yeah, I think the only thing I would say is to take your meds. I mean, that's all. Because a lot of times, patients kind of think, oh, I missed that dose, I missed this dose, it's not going to matter. And, it's adherence to medicines is tough, but it's really a life-saving thing. So that would just be my last kind of words of wisdom.
Great. Well, those are smart words to end on. So again, thank you so much. This was terrific. We really appreciate you taking the time to teach us this evening. And thank you to everyone that joined us tonight. We appreciate your time, and our next group isn't too long from now, actually. It's on April 8th at 7 p.m. And Dr. Christian Ruff is going to be speaking about the connection between genetics and blood clots. So we hope that you'll be able to join us then. And thank you again, Dr. Heilich.
Okay, thank you, everyone. Have a good night. Bye-bye.